Thank you. Hi, everybody. I'm Raana, working as a specialty doctor in NHS Tayside, and my audit presentation is on the subject of changes in number of sections as CAT1 due to cord prolapse. And it was observed that before we were using Cook's balloon for induction, number of sections for cord prolapse was less as compared to when we started using this method of induction. So I did this study retrospectively, and the year 2019, all number of sections we had due to cord prolapse, and there were inclusion and exclusion criteria, definitely. And then this number, and then Cook's balloon was started being used for induction in 2020. It was during the times of COVID. So 1 year after that and 1 year before that. And the study I conducted was in Ninewells Hospital, east of Scotland. So a criteria was that number of CAT1 sections due to cord prolapse. I'm sorry, I want to define here for those who don't know. I'm sure majority of you know that CAT1 section means there is immediate threat to baby's life, baby or mom life, and we have to deliver baby within 30 minutes. And cord prolapse is one of such emergencies where once it starts affecting baby's CTG or heart rate, then in that case we have to announce for CAT1 and have to deliver baby as soon as possible. So number of CAT1 sections due to cord prolapse before Cook's balloon use compared to number of same after starting use of Cook's balloon as method of induction, and case files reviewed for 1 year before and 1 year after that method started being used in maternity system of Ninewells. And our standard target was that CAT1 section due to cord prolapse after use of Cook's balloon should be reduced to minimum by setting standard guidelines for use of this balloon in Ninewells. When we go through guidelines, we do not find any standard guidelines, but there have been very, very few studies, which I mentioned later. There was a very good study which was done in Japan about the same subject. So data collected was from women booked for IOL by Cook's balloon as in and outpatient, because not all patients who are induced by this method, they are inpatients, but they can be sent home safely because it is sort of more mechanical than chemical method. So that's why we can send them safely home if they are suitable for that. Though not all of them, they cannot go because, for example, if we are using this method in previous history of section, in that case, we don't send them home. Data collection was retrospective for 2 years before and after this method induction, and data was anonymized. Total number of CAT1 sections from January 2019 to December 2019 were 123. And this was number of CAT1 sections, and only one section was performed for cord prolapse during that time. And that cord prolapse section was, when compared to the year after induction of Cook's balloon, then the number of CAT1 sections, like it was just a coincidental finding that the number of sections was same, it was 123. However, cord prolapse sections were 8. So the one which had cord prolapse before induction of this method, that was primi gravida who had induction of labor with PROPES at 38 weeks plus 2 days, which was term pregnancy. And the reason of induction was static growth at 10th centile. On examination before ARM, after receiving PROPES, it was 3/5 palpable, and then her waters were broken and the cord prolapse detected after 5 minutes of ARM with a normal CTG. So when CTG was abnormal, she was examined, it was found to be having cord prolapse. At this point, ARM was done by midwife, and there was no cord felt around the head when she was doing ARM. So maybe after that, maybe it was for any reason, if head moved and cord came out. Action was that she was taken for CAT1 section, smooth section under spinal, because they got time to do that, because if CTG allows us, then we go for spinal instead of general anesthesia. And baby delivered with APGAR score of 8 at 1 minute and 9 at 5 minutes, and average blood loss was noticed. Now I will come to the cord balloon sections after induction of cord balloon. Sorry, after induction of Cook's balloon. Cook's balloon was introduced to Metnine Maternity Department for induction in 2020, and Cook's balloon it is a silicone tube which has two inflatable balloons which are inserted and inflated with normal saline and deflated before removal. So as the balloon does not contain any medication, it reduces the risk of side effects which are associated with prostaglandins. And once inserted into the vagina, the Cook's balloon will usually stay there for a maximum of 12 hours. This is as per the balloon company, their own guidelines, and we were using the same. Though in some trusts, they are using this for longer hours. In our trust, we fill balloons with 80 ml of normal saline, intrauterine balloon and both vaginal balloon, they were filled with 80 ml of saline. However, it can be changed if patient complains of pain, and it is usually reduced if they start feeling pressure down there, if they have any remarkable pain. However, we never made a rule to make it less than that. So total number of Cat 1 sections in this year, after we started using this balloon, Cat 1 sections were 123 and cord prolapse sections were 8. Out of those 8, one was for a para 2 with premature preterm rupture of membranes, and that was at 26 weeks, which is anyway a high risk for cord prolapse because baby is small, and at this gestation, the cord prolapse risk is anyway there. So this patient was excluded from the study. One of them was para naught, like primary gravida. She presented with spontaneous labor at 42 weeks, and her ARM was done for slow, and she had ARM, she had slow progress, and her presenting part before doing ARM was 3/5 palpable abdominally, but still after ARM, she had cord prolapse. So again, this patient was excluded from the study because this was not related to induction with balloon. Now, 6 patients were left, and all of them, they had induction of labor for different reasons. One of them had PROPAS, and then she had, one of them had only PROPAS, no balloon, and 3 had balloon. The one who had only PROPAS, again, she was excluded from the study. And one of the patients, she had both PROPAS followed by the balloon. And one of them had none of these and was ARMed only. Rupture of membranes was done. One was primary gravida, one was para 4, and 2 were para 1. And common points were that in all of these patients who ended up having cord prolapse, their presenting part was high abdominally, and it was before insertion of balloon. So point here comes that if it was high at 4/5 palpable, it means it was not fixed, it was not engaged. So in that case, inserting 80 ml of fluid in the balloon, definitely we are just pushing head out of the pelvis. All of them, they had ARM and cord prolapse, which was not found at the time of ARM, but after a couple of minutes, CTG changes noticed, and then we examined and diagnosed as cord prolapse. So again, I would say that when ARM is being done, the standard practice should be to feel if there is any cord or anything, or if head is well fixed or not, whether it should be controlled ARM or not. But depending on the person who is doing ARM, what is their experience and what they are having in their mind, it could be possible that head is not well fixed, but still you are just doing a blind ARM. You are not taking care of having a controlled one. So these are the factors which can affect it. So on abdominal palpation before induction, 3 women had 4/5 palpable head, and none of them had controlled ARM, as operators found it easy and did not need assistance for control. This is their assessment. One woman had 2/5 palpable, which means we would say that it is very well engaged head. So yeah, in that case, it was not expected. And that baby was STA, it was only at 6th centile. So again, small head already has gone down, very less chances to have this. This I'm discussing that before balloon, what was the assessment? So even in this case, before inserting balloon, we would think, oh, very less chance because already head has gone down. And one woman, she had dichorionic diamniotic twins with 4/5 palpable presenting part, and she had cord prolapse after ARM. So the outcome for all these sections was that all sections were smooth and they were done under spinal due to active management of prolapse, and they got time to have like to keep cord away and to avoid pressure on the cord, and they got time to for in spinal, and then sections were smooth. Outcome for all babies was good and had good EPGAR score. None of babies needed NICO transfer or admission. All babies were above 50th centile except one that was SGA and at only 6th centile. And I again want to mention that this study was done in a developed country where theater is just next to the labor ward and very well trained staff most of the time, and we can do things in time. So if the same thing would happen in underdeveloped countries and in our developing countries, then I'm sure that the results would be different. But here, because it is sort of drills are going on every other month, so that's why they were well trained, so the outcomes were much better. However, there is always something can be done to improve the things. And again, in this case, our main concern was that we should not reduce the number of sections by changing our practice. So number of cord prolapses were markedly raised in 2022 as compared to 2019. It was 7 times after exclusion of pre-prom. In pre-prom, as I already mentioned, that this is one of the expected complications. Cook's balloon-related CAT1 sections were 50% of these total cord prolapse CS. So Cook's balloon increased risk 3.5 times. Patients with CAT1 section following balloon induction were 4, and 3 out of 4 were having high head-on abdominal palpation, but controlled ARM was not performed. So discussion points were the transcervical balloon catheter increases risk of cord prolapse. And again, the reason could be increased volume of saline used to inflate uterine balloon. It also increases risk. Parity did not play any significant role in this scenario. And in these cases, cord prolapse was iatrogenic and preventable. And it's highly likely to have spontaneous rupture of membrane and cord prolapse for patients who are discharged home after Cook balloon. So recommendations after consulting few studies were that decision of balloon or process itself should be made by senior midwife or a doctor after palpation abdominally and having an idea that how engaged head is, because in case if you have already a free high head, in that case, by introducing an 80 mils balloon below the head, you are increasing risk of cord prolapse. And also there should be a vaginal examination assessment. All patients must have recent presentation scans because again, low risk patients, when they come for induction, they are not, as a part of routine, they are not having scans. They are just palpated by midwives and balloon is inserted. And most of trainees from ST3, they are competent to do presentation scans. So it can be made a practice that all of the patients who present for induction should have presentation scans. And in most of the trusts, it's happening already. If on abdominal palpation or vaginal examination, head is still high or it is not well fixed, then Propes should be preferred over balloon, because with Propes, Propes is a prostaglandin used to start induction, and that will start causing tightenings and will start uterine contractions. Those will help to push baby's head down in the pelvis. Presenting part is a 4x5 palpable or more. In that case, we should not send them home with balloon, as they are at increased risk of cord prolapse after membranes rupture, if membranes are gone at home. Uterine balloon volume can be kept at 40 mils or less, as it's associated with less risk of cord prolapse. And this point was taken from the Japan survey, which I will mention on the next page. And they mentioned this, that even it can be started with the 40 mils or even less, because the main purpose is that we want to separate membranes from the cervix, and they will start producing prostaglandins, and then that starts to help onset of labor. So even with 40 mils, it can be done. So some of the recommendations, some of the points here are from PubMed Central 2015. They say that the use of balloons for uterine cervical ripening is associated with an increased risk of umbilical cord prolapse. Population-based questionnaire survey was done in Japan in 2015. This is the first large population-based investigation to demonstrate this increased risk. And interestingly, after that, I couldn't find any investigation or any survey or any study done on a larger basis. So out of 369 cases recruited in this study, 1/4 of cases were positive for cord prolapse. The mean plus minus standard deviation of the amount of water used to inflate the balloon for cervical ripening was 43 plus minus 6.7 mils of intracervical balloons. So none of them in Japan went to 80 mils, which we are using, and most of the trusts are using here. However, it is supposed that the increased risk of umbilical cord prolapse in case involving the use of an intracervical balloon filled with approximately 40 mils of water, it was limited, as the incidence of umbilical cord prolapse after balloon removal did not differ between the patients treated with and without an intracervical balloon. So they sort of recommended 40 mils of water used to inflate the balloon, as it decreases it, as it does not alter the risk of having cord prolapse. Another point which was also mentioned there was ultrasound confirmation of the umbilical cord presentation to diagnose before laying and occult prolapse of the cord prolapse before balloon placement. After and prior to removal might improve perinatal outcomes. So it was to do a scan in addition to presentation scan to confirm that cord is not already in front of the head, or it is not just next to the head, or before doing ARM, another scan to check there is occult cord prolapse or not. So this scan, as it needs to be done by experienced persons, and it cannot be done on duty doctors most of the time, because not all consultants, they are trained to do these scans. Also on night, like when consult out of hours, they are not on the floor all the time, and lead of the maternity group is usually ST3 and above trainees. So they are not trained to do scans for presentation of cord in front of the head or there is any occult prolapse. So this point was not, I would say it was not practically possible, or very, I won't say not possible, but it was very difficult for us to start using here as a routine. So even when umbilical cord prolapse did not occur during the use of a balloon or at removal, it may be possible to preserve elevated fetal presenting part out of the pelvis. And when it goes out of the pelvis, then it could cause or it could induce wrong rotation of head, resulting in umbilical cord prolapse. So for example, if head is pushed out of the pelvis and it rotates a bit, and then it can give some space, it can give window for the cord to come out after when membranes are ruptured. So this is one of the risk factors. And furthermore, the use of a balloon may involve occult umbilical cord prolapse during the procedure itself. When we are doing that procedure, when we are inflating that, we are pushing head out and we are giving, as I already mentioned, that it could be a rotation thing which can increase your risk of prolapse. After which umbilical cord prolapse is detected due to identification of the descending fetal presenting part or rupture of the membranes. So it means already this cord was hanging around head at some point, and then when waters were gone, whenever it got a chance, it came out and caused clinical cord prolapse. So the changes we made in practice was that patients should have abdominal palpation and presenting part engagement assessment before starting induction. It should be made sure that she is having presenting part head. Plus, it is not free floating. She should also have a vaginal examination to see whether, because it is not always only abdominal examination, but how vaginally head is fixed or not. Also, if we can have a scan before breaking waters to see whether there is any occult cord prolapse or not, that would be helpful. However, it cannot be done in every patient, and we can train our medical staff to practice all these points as the part and parcel of this balloon method, and hopefully that will help. So we have started all these points already in our trust, and we will do another audit after 1 year to see if there are any changes. Thank you, everybody.